Good afternoon, everyone. I should like to introduce myself. I'm Vana Kekatou. I'm Editor-in-Chief in Hertz and Health U, Director of editing team. So I'm moderating this discussion that has to do with a very interesting idea. An idea that could be, Columbus's egg in many issues faced by the healthcare system. It's an idea that's not a novel one. From as early as 1992, there is a provision for a hospital-at-home service, even in 1983 for psychiatric patients. So today, 30 years later, we're discussing how this, generally unknown idea, it's unknown to the patients and unclear for those dealing with health-related issues, can become more precise, more clear. I think we have the appropriate speakers. I should like to welcome them and give the floor to the institutional representative, Mr. Ioannis Kotsiopoulos, who is Secretary General for Health Services with the Ministry of Health. Good afternoon. Thank you very much for inviting me to this conference. It is very important to open the dialogue to include new innovative health models like the hospital at home. Like you said, it started very, very slowly and for quite a long number of years, but we can move on to a new phase, to redesign health services. And to speak the truth, this discussion stemmed from a discussion I had with Dr. Tsanakas, who does the pediatrics hospital at home, who explained the story of a young child, Konstantinos, who used to live outside Thessaloniki. He was a healthy and active boy who contracted a very rare heart disease that forced him to stay in the hospital for a long time, which also forced his family, his carers, to move to the center of Thessaloniki from the area they lived, to spend long hours at the hospital. And there, the idea was born as to how we can hospitalize these children closer to its carers. So Dr. Tsanakas explained to us the entire scientific model around pediatric hospital care at home. It concerns children who are in need of intensive care at home, which can be done with safety. And I think we have a couple of slides to show, don't we? So from that idea, what stemmed was to see whether we can expand this model of care, not just for children, but also other patients who need care at home for other ailments. And could I please have the clicker? Right, okay. Click, click. It's working? Right. Whether we can expand it to cover other groups of patients to offer services at home. Patients suffering from, heavy ailments who need to spend long hours at the hospital. People who need to be constantly rehospitalized and their patients who have to suffer through hospital infections. People whose family suffers from the fact that they need to care for them over long times in a hospital setting, which entails an indirect cost for the family and a direct cost for the state that needs to care for a patient in a hospital setting. So we're trying to come up with a model in which the patients will receive better care at home by a healthcare team comprising nurses and doctors with less cost, with more safety and in a better environment. We filed this as a project with the RRF. It was approved by the European Union, so we do have the funding to start it with 14 million euros. It can start very, very soon. In the next few months, we have the entire preparation, so it will start sometime in November or December at the latest, and it will comprise these 4 sub-projects. The first sub-project is the upgrade of the institutional framework, because there is an institutional framework in place covering hospital at home. But this does not cover the additional medical actions that will be required for hospital care at home, which, as I explained earlier, pertains to some specific medical acts that may not be performed outside the hospital setting. The second has to do with the use of technology. It's very important. It's not something we used to have in the past, Mrs. Kekatou, when we first introduced this project. Now, with telemedicine and telemetry, we can monitor and follow the patients at home. They can be connected with the information systems of the hospital, and when the nurse or the doctor visits the patient at home, we have set up an environment that is similar to an ICU. We have the systems that communicate with the hospital systems, and we can provide safe care at the patient's home. The third sub-project is the building of 8 centers in 8 hospitals. These centers will offer this service. In the beginning, we would have liked them to be more numerous, but the project is rather limited in its funding, so we can only cover 8. They will start on the current institutional framework. When we pass the new one, they will be upgraded, and we will be able to have additional medical actions and there. The third is to measure the quality, the indicators and the indices that will measure how much better care these patients have. So we start with the current institutional framework that was passed in the summer and allows us to do more things. We still have a ministerial decision that needs to be signed in November so as to kick off. The new legislation, which is a deliverable of this project, will be expected around spring 2023. So is it worth it? Of course it is. Here I have the photograph of a child that received. This is a photograph of Konstantinos, the child I explained about, who is no longer with us. This boy told Mr. Tsanakas something that says, if we get better and become better, everything will improve. So it's up to you and the rest of the speakers to explain how we can offer more services of oncology care. It's not just cardiology. We already have in the States oncology patients receiving hospitalization at home, and to do this in our hospitals as well. Thank you very much for the first presentation. You were on time. I have a host of questions, but I would like to to hear from the other speakers. So I will give the floor to Mrs. Olga Balaoura with the Savvas Hospital, the oncology hospital, for her introduction.
Good evening. Could I please have the pointer? Thank you. In Savvas and in the goal-setting framework, and with the assistance of Roche and Ernst Young, we submitted a technical bulletin. That was a detailed study on a program for oncology treatment at home. We called it ECOFEN, which means from the house. And it is a very specific title. We saw that with the available resources of Savvas, if we were to develop home care, we can indeed have an oncology treatment at home and really upgrade the life quality of patients and be far more cost effective. Here we depicted the whole existing situation, the status quo, so as to reach the procedures that we eventually submitted so as to have a complete study. I do not see this that far away, so we'll adopt Mr. Ifandopoulos' method, Professor Ifandopoulos' method. I will be errant, strolling around lost my presentation. Thank you. So, as you see, we planned the service ECOFEN from the house, recording our resources, the resources we had at the hospital. So we described the situation, that is, setting the question, what would we need to do to perform today? So we had the analysis. We recorded how many treatments we can have per week, how many people, personnel, and how it would operate. The next stage was ECOFEN 2, one step ahead. We even reached ECOFEN 3. I apologize for the slides, the way they come. So we recorded the existing situation, and we saw that we actually had an absence of such a service. So we said we are to develop an innovative model of home treatment, because otherwise we have time delays, we have transport delays, we have important problems of hospital-afflicted infections, who have bad psychological condition of the patients, who have need for increased home care. Family environment, especially for cancer patients, plays a very important role in their mental boosting and therefore their improvement. So we depicted what we have. The first is Nikos Kourkalis. This is the daily care unit we have. By recording the procedures that we have there, KIN, this is the unique such unit, public oncology unit, that is accredited of 152004. So we recorded the existing situation and we moved on. We said, this daily care, let us try and offer it at home. So we started describing Ecothen 1. Ecothen 1 means that Savvas, having the legal framework, can launch it tomorrow. Now, Ecothen 2, which is an upgraded service where we have the involvement. We actually broaden our geographical scope. We upgrade our services. We introduce additional services so as to have medical files, have a real-time communication of doctors with nurses that go at home. And we move to Ecothen 3, which is a wonderful project at national level where this includes covers all the hospitals that have the available resources to be able, if they have the resources, to adopt the study and therefore adopt Ecothen at any moment. What does Ecothen 1, 2, and 3 entail? We have calculated everything in months, in teams, in personnel, what we need in digitized services. You see that in bullet points, but actually imagine that under each bullet, each line, we have all the services and necessary resources. What are the benefits of this program as we describe it? You realize we speak of far more qualitative services in a familiar environment. This is of great psychological boost for the patients, reducing time and the risk of hospital-afflicted infections, respect to the dignity. We have the family close and next to the patient, great benefits for the hospital, great reduced waiting lists, a gradual reduction of cost, an increase of services quality, greater coverage in numbers, greater access and to funding, competitiveness, and we have benefits for the national health system, attaining the main goal for a qualitative health service. Anyway, this year in the European Union, whatever concerns cancer patients is of immediate priority. Savvas, following this policy, has entered the process of accreditation as comprehensive data center. We are the unique cancer hospital entering this process. Of course, we need 2.5 years to be accredited, but we have launched the process and we start adopting more qualitative approaches and procedures in our hospital so as to be better, especially vis-à-vis the patient and then to the personnel as well. Methodology that we applied, yes, and Young will present the methodology, so I leave the slide, because we spent hundreds of hours on this huge board where we would depict each procedure. But within this part, we included the interviews with hospitals that already apply this program. We spoke mainly with the UK and Christus from NHS, and they were really astounding experiences. We saw patients that have taught a radically different profile. There are other people after this home care. We spoke with physicians that could coordinate that, and do not imagine that had more resources than us, because the geographical areas would cover, it's as if someone left Savvas and offered this service to Lamia, huge distances, nothing to do with Greece, really. Here's what I said beforehand. We have depicted, we have KIN, that is a Kourkalis Daycare Center, and Savvas. So we have depicted what the daycare center offers, so as to have the treatment offered at home, and what the Savvas departments must do so as to support that. This is very analytical. We have every detail from the way we will have the preparation of the substance of the medicine in the hospital until how it will securely reach the patient, how it will be administered, if there are complications, how the patient will come in contact with the hospital, the whole technology needed, all the resources. You see, the transportation, the treatment, the orderly and nurses, the collection and disposition of waste, the hospital waste, technology. I put that so as to prove to you that we've examined everything in every detail, minute detail. Not all patients can be included in that. There are specific criteria for integrating these patients. I have no physician here to analyze that, but I can give you it roughly. The attending physician will select the treatment. We have specific drugs that are included in the list. Not all treatments can be offered at home. The patient must definitely to have done the first 3 cycles of treatment at the hospital so as to know that there's positive response to this treatment, there's no counterindication. He must be in a phase of maintenance with the drug. There must be a stability depiction, a resonance stability. He must also have e-prescription because, of course, we update the medical file. The patient himself and his family environment must be cooperative and be able to communicate with the doctor and have it in connection with Nikos Kourkoulos. This is the first step, communication spot in the case of adverse effect, and then with the hospital at a later stage if there's something more critical. I gave you the benefits of the system. For us, this is of the utmost importance, and we look forward and expect the legal reform from the Ministry of Health so as to immediately implement those changes. Thank you. Thank you. You were very convincing, I must assure you. Well, benefits might be given in a bullet points, but it was fully understood how important they are. So let us come to the private sector. Madam Angeliki Angeli from Roche, Hellas. So we look forward to listening to you. What synergies can we have for the private sector to cooperate with the public one so as to accelerate this plan?
Right, brilliant. Thank you very much as well for the invitation. I will try to convey all this information surrounding this activity described by Mrs. Balaoura. What is the role of a pharmaceutical company and how they can be a true partner in such an endeavor that is exceptionally beneficial and forward-looking and beneficial for the health system in general. I will be focusing on why a company like Roche undertakes such a feat and tries to help. Focusing on 3 main pillars that, if we take the example of cancer, for instance, which is a field of expertise for Roche. Our goal and aim is to help solve the problems experienced today in the country concerning this ailment and the 3 pillars that you can see on the slide. It has to do with the actual focus on the patient, patient-centricity, and what actions may be implemented. This pillar includes the example we are discussing today and 2 other pillars that have to do with the system funding, the healthcare system funding, various solutions and thoughts we have, but also the very important issue we're discussing of the lack of data in the system. This 3rd pillar is working cooperatively and jointly with the other 2 under discussion. We are envisaging and working for the past 2 years with the thoughts of offering innovation to the health system and mostly to the patient. Above and beyond drugs, above and beyond treatments, we no longer want to manage the problems we have in front of us as a company that brings drugs to the patients. But what we want is to really be partners with the healthcare professionals and the healthcare system. through co-creating solutions for patients. So with this vision in mind, we transition to Ecothen, as presented by Mrs. Balaoura in the beginning. Our thought and our aspiration was to optimize, in general, the patient's journey, striving to create value in every step of the disease experience and how we can help them manage it better. So if I may run through what was presented as a final product by Mrs. Balaoura, I should like to say that we started by responding to Savvas Hospital initiative to help co-create a solution that would standardize oncology patients. We evaluated and assessed, I can hardly read the font, says the speaker. We explored the spectrum of solutions to find the most efficient one that meets clinical and safety guidelines and considers capacity limitations. The next step was to verify the need and pulse check the solution's feasibility with other ecosystem stakeholders, whether it is something viable. The following step was, respecting the vision I described earlier, we identified a solution that would allow this standardization to be adapted easily by other hospitals in Greece that meet the criteria for all oncology patients. Having taken all these steps, we designed a cancer patient-centric home care prototype, the details of which were detailed earlier, working with Ernst & Young, which we delivered to the Savvas Hospital and the Ministry of Health, integrated, complete and whole, so as to be able to be used the day after. The benefits were mentioned already. I should only like to focus on the huge benefit for the patients, upgrading their quality of life. We can all clearly understand how much difference it is for a difficult disease such as cancer, a patient to be able to receive their treatment at home, at the time they choose, the day they select, and for the time interval they opt for, rather than having to go through the ordeal of going to the hospital every now and then. In conclusion, I would like to say that Ecothen and the delivered solution is turnkey. It's ready to be implemented tomorrow, once the legal framework is in place. As far as we're concerned, we aspire, and it is our vision, to see this solution being adopted for cancer patients across Greece. And why not similar ones for patients in other therapeutic areas facing similar challenges of patients having to go to hospitals for their treatment to be administered. Roche is a company that wishes to continue to partner with the ecosystem and primarily to co-create and support integrated solutions along with the other stakeholders that improve patients' experience in the system throughout their journey concerning their disease. In conclusion, I should like to express our sincere thanks because this project was a particularly demanding one and time-consuming, if I may say so. I want to thank Mrs. Balaoura, first of all, and the Savvas Hospital. The first internal medicine clinic, Professors Ioannis and Nicolaou, who worked in true depth in order to have something tangible that could be used by the ministry the day after. Definitely the ministry and Mr. Kotsiopoulos for lending us an open and receiving ear to adopt something innovative to the benefit of Greek patients. It is particularly important, and it is a huge positive step in the right direction for the country and the provision of care and treatment and therapy for Greek patients. Ernst & Young, because the help of E&Y was particularly valuable throughout this journey. And last but not least, the internal team of Roche, for the perseverance they exhibited, their devotion and dedication to the project. I want to help them. Sincerely, they managed to make the impossible possible, and let's hope that we will see it take action, Mr. Secretary General, so that we may offer this level of care to oncology patients all over the country. Thank you.
Thank Madam Angeli. I believe the Secretary General said that he is ready to have this program implemented starting tomorrow, although we have to wait for the law until the beginning of 23. Yes, there is a ministerial decision that is currently being drafted in the Ministry of Health so as to start. So we can start with the existing resources of Savvas, because we have made an analysis with Madam Balaoura that we can launch this project immediately without additional funding from RRF. Once we have the additional funding from RRF, we will have an extension of the project in the other 8 centers that will be selected. Fine. Now we give the floor to the last speaker, Mr. Yorgos Mitropoulos, who is in charge of healthcare and life sciences in Ernst & Young. You have the floor. Good evening. A difficult and rough time. We have no one putting pressure on us at the end, but I will observe the time. The motto of EY is building a better working world. And in this project, we felt, us and all the teams we cooperated with, we really felt that we building a better world. We really worked for something that would be good in our small world, if you like. Micro world. Madam Balaoura said a lot about the project of ECOFEN. I will try to show you the backstage, behind the scenes, how we did it. So, when we started, the summer of 2021, discussing this project, we quickly realized that this was not a project regarding a scientific dimension, and we would not be able to help in that anyway, but had many facets having to do with organizational and administrative aspects. From the processes that had to be identified, followed, recorded, technology, and most importantly, the legal framework. We did have a legal framework, but not the one that would determine the operation of the service. And this whole project had to be based both on global practice that we would have to find from organizations such as Christie that was mentioned beforehand, and the locality. This was the most important mandate we had, that is to have what's best for the Greek patient. From the onset, we had a vision of contribution, a commitment that was matched both by Roche, Savvas, and the ministry. We worked in depth. From our side, we had 7 sub-teams with more than 10 or 12 specialties represented, both from Greece and abroad, specialties having to do with health, but not solely. Finances, legal department, technologists, engineers, and having to do with personnel management, so forth. So it was a transversal team that worked excellently together, and it was an excellent experience for all of us. I didn't let Madam Balaoura to take away my slide. This is the methodological tool we used. We started by trying to understand the current situation. What was a patient's trip? We started from Nikos Kourkoulos and Savvas Hospital. We spoke with personnel, both not only physicians and nurses, but also the legal department and other departments of the hospital. And most importantly, we took interviews from the patients. For us, who do not have a daily contact with patients, this was an eye-opening experience. This made us even more committed, becoming more committed when we had the patients explaining the need for this service, for Ecothen, because both for sentimental, emotional reasons, that they have a negative feeling when they go to the hospital. No hospital creates positive emotions, not even an obstetrician's hospital. But also for practical reasons. Some told us that in the middle of COVID, I have to take the bus or the mass transport because I cannot afford a taxi for my treatment. Things these are daily routine. So we depicted the current situation. We viewed what we can keep from the current situation, what are the characteristics that must stay, because let us not forget that there was already a center for home care in Savvas, and we tried to find the best cases. So we examined the USA, the UK, Australia. These are the three countries that have already a successful implementation of this service. And on the basis of the knowledge we gathered and the contribution of the team and the other partners, we jointly planned the future trip of the cancer patient in this service. And then we viewed all the dimensions of that service. So this trip starts on specific steps: the entry, admission in hospital, programming, the test labs, the transition, the treatment, the whole process until the ongoing monitoring. So for each step of each lap of the travel, we examined what the patient must do, how he feels, and what would be the best experience in each step. We examined the medical team, the attending physician that is, or the nurse that we will do. These are the foreground people. What are the steps that they should do? What are the risks they are faced with? What should they pay heed to? In the backstage, the administrative staff of the hospital, the supervising physician, the drugstore, even the car team. What is the role of each one? How are they to support the whole trip? And finally, technology, most important part. What technologies can we use that are already available, or what new technologies should be introduced? For this whole trip, therefore, which obviously was examined in great detail, we had to view all the dimensions and the substratum, start seeing the processes needed, how we'll be governing the organization of all that. Will we have a separate department? Will it be in the hospitals? What are the precise roles? What are the indices, performance indices? What will be considered a good place? The personnel training plan, currently they are not ready. So we had to establish a plan of where and how they would be trained. Equipment that the team take with them and technology, risks that they are to face, financial issues, how much that will cost, what will be the benefits, what is the cost-benefit relation, and last but not least, the legal framework, as we said. Therefore, work has been done in a very great detail by the EY team. I think we have helped enough so as to be close to the next step. This was shown by Madam Balaoura, and I'd like to show that when all that was completed, we were at the point that dubbing the whole project, how that would be. That was also a nice experience, finding the name. Thank you for whatever questions, perhaps on a bilateral level at the end of the conference. Thank you.
Let me start with you, Mr. Mitropoulos, the journey of the patient. You said that you used as a best practice model some models from England. I wanted to ask, what are the particularities of Greek patients, and what were the things that made it difficult for you to design Ecothen? Truth be told, largest part of best practice had to do with how the organizations dealt with the patient. And it was the biggest lesson learned. It was that patient particularities are at the epicenter of everything we do. So we didn't have any exposure as to what British patients are like, or American patients, or Australian patients, but we did see is that the way they're dealt with is particularly cooperative. There were some practices that had to do with clinical effectiveness or efficiency, with safety or with lifelong learning that would be expected by any care service or agency, but there were other parts that had to do with the fact that the patient is at the center, how the patient receives the service rather than how we offer it. It was a different point of view, okay? It's a different aspect. Equality. There are very specific criteria, like Mrs. Balaoura said, that I make public, there is transparent, this is what you do. If you don't meet the criteria, you're not in. Communication, so constant communication with the patients, using a particular language and a particular code with the patient and with the carer. Because as we know, this thing does not end when one receives the treatment at home or the hospital. It's an ongoing thing that lasts for some time, and it involves all the people in the patient's environment. Right, thank you very much. Moving on to Mrs. Angeli now. So, of course, this is oncology patients, okay? Are you, as a company, ready to expand Ecothen to cover other categories of diseases? Right, yes, well, indeed we are, and we've already started collaborating on another disease. Which one is it? Are you able to divulge? Well, maybe we shouldn't discuss this because we should allow it to start first. But in principle, it's something we are focusing on because we want to participate in a fundamental, in an essential way to help the healthcare system by making moves and acts that help patients in their everyday lives and the problems they have. And if you'd like to upgrade our health system as a whole, I believe that this move overall, given the difficulties we had to go through, and I'm talking about the coronavirus crisis for 2 years, and we saw how difficult the access of patients was, how they delayed to receive their treatment, or how they didn't have their treatment administered at all. I think it's a step in the right direction. It is a prioritization for us to facilitate patients in their treatment. Mrs. Angeli, you mentioned the pandemic. How much did it affect the planning of Ecothen over the past 2 years? Right, well, maybe it accelerated it slightly. In principle, the focus, as far as we're concerned, but I believe also of all the participants in this roundtable, was our intention to improve everything and to move in that direction overall, not just Ecothen. If you'd like, the pandemic urged us to do it faster and to do it more fervently and more energetically, because I believe it's clear to understand that when we started talking about this, even amongst ourselves, it seems impossible at first glance. How does one start discussing about taking treatments outside the hospital that for decades or a great number of years have been administered exclusively at the hospital? This is the way it's being done in the country and in all countries. And all of a sudden, we're discussing of making the impossible possible. So, like Mrs. Balaoura says, we're not talking about all treatments. We're talking about what is appropriate health-wise for the patient. But there is also a middle ground. So it was a difficult endeavor from the onset, with a huge vision in front of it. But I believe that the passion of all of us here and the groups and the teams that work behind us at all levels, I believe I'm speaking on behalf of everyone, was what made it happen. And what we have is a very integrated result. It's of great importance to me because it's something that is implementable tomorrow, as long as there is the will on behalf of the ministry, but also from each hospital, the administration of each hospital, because we also have that dimension, the hospital administration dimension, to introduce such a structure as necessary in order to make it happen, because maybe Mrs. Balaoura is the competent person to say so. It's not something that's done automatically. It takes process. So Mrs. Balaoura is more of a specialist, and you asked a question that is one I share. So how are we talking about treatment being removed from the hospital and going to the patient's home? Does it take some specific or special equipment to be installed in the patient's home? How feasible is this overall? Right, now, the pandemic, and thank you very much for this pass. The pandemic was a factor that urged us to do this, and this was not a purely Greek phenomenon. It was a, global one. Everyone had to deal with the problem of the pandemic in the hospitals. What happened? Well, patients who were hospitalized all of a sudden were infected with coronavirus. The result being an increased burden of their situation, to have problems, as you can understand, huge issues in their management, internally, in the clinics. So yes, coronavirus was an accelerating factor. But it was an international trend, nonetheless, to remove patients from hospitals for a great number of ailments. It is being debated and discussed for a great number of years. The United States have been implementing it, England, the United Kingdom, using coronavirus as a springboard. So we did the same thing. We held the discussions. We found Ernst & Young and Roche as our partners, and primarily the health ministry for supporting it. We had a common target setting, a common focus, and so we started. Now, we're discussing how feasible it is. Now, there is nothing that is impossible and non-feasible. All it takes is good planning. Patients don't need to have anything at home. Everything is arranged and taken care for. The dialysis of the cell statics happens from at the hospital, the way it has to do. There are specific transfer times and transit times using specific technology that has been pre-calculated and taken into consideration in our planning, and we know what it needs. So there is nothing that's non-feasible. Patients are in their environment and they wait for the doctor and the nurse. And we're saying about doctors now, well, in a future, more ideal system, we may not even need a doctor. Abroad, in the United States and in England, doctors don't make house calls. In this case, it's just the nurses or the carers. Now, our system here is slightly less lax, let's call it that. So on our first design, and the plan was for the doctor to make a house call and monitor the patient. So the doctor who will go there, or the nurse, will they have received some special training? Yes, well, they need to be trained. Now, anyway, in oncological hospitals and doctors and even nurses who administer oncology treatments have received specialized training. I mean, even in the daycare center we have. It's something that we do and we need to do. It's the lifelong learning that never stops. It is something that is perpetual. You mentioned during your presentation already, but I would like to ask you this. Which patients meet the criteria for inclusion in this program? Which is something I like very much, Icothen, at home, and even from home. Well, it's best because, well, Icothen means from home, and Ikade means to the home, at home. Now, we wanted to give this that from home, you are being treated from home. You can this from home. So it's hospital at home. So we want everything to be done from home. So there was a huge debate about the name, so we came up with Icothen, which means from the home. Now, the requirements are very specific and very strict. What I showed was part of the requirements. There are other things and requirements that need to be met. The key thing is that the patient must have gone through the hospital, done 3 cycles of treatment at the hospital. Not all treatments may be covered. I don't have my doctors here to analyze it, and I'm not the most appropriate person to do so. But these very strict requirements are there. There is a specific molecular profile for the patient who are able to support this. But I assure you that if you want to talk numbers, it's a tremendous percentage of the patients that could be dehospitalized and receive their treatment at home. Right, brilliant. Mr. Kotsiopoulos, you're last. Definitely not least, as to the question I want to ask. But I believe that your answer will be a crucial one. You made a link between the program, and the RRF. We've already filed for the first installment, and on Friday we are filing for the second installment. The money will be disbursed in October. So are we ready to start with the program immediately? So come late October, if I meet you someplace and I ask you, is the project on? What will you say? Let's take a step back. It's very important, and we shouldn't leave here without me having stressed this. It's very important to say that these attempts, these efforts, started in tandem, in parallel. The ministry started looking at hospital at home, and Savvas came here to complete our thought. So what we did is we brought together two programs to create a national project for hospital at home.
Savvas does have the means to proceed even tomorrow because they have all the resources and personnel to do so. So once the ministerial decision is issued, they can start. The other centers need to follow a procedure. There must be a call for tender, which will take place over the next 2 months. Because indeed, as you said, the RRF has approved the budget. We are within the approved funds earmarked. We can start. So we'll also have the operation of the other 8 centers for home center, not all for cancer patients. There will be also other diseases. It would be multiple sclerosis, renal diseases, patients that have to visit hospitals very often, and we may see them also in urgencies along with all others for their admission. So we want to free them from this burden. And once the program is launched, many patients will be relieved. Of course, we realize some patients who are in more grave situation may need an additional equipment to be installed in their house. Some of those cancer patients do not need additional equipment, but not every center operates the same way. We are very fortunate that such a huge work has been done in Savvas, and I would like to thank all those groups that have worked and offered the deliverables and will be leading us for the other ailments. So I believe that the answer is yes. We start immediately, both with Savvas and all the other centers. Thank you. I believe that all 4 speakers referred to the legal framework. What are the issues that have to be solved so as to have your hands untied? Well, with the law adopted in summer, we have an open road for the home care. So now we can really start delivering drugs at home and treating cancer patients. What is pending is some terms and conditions on how this will be affected. With regard to ECOFEN 2, then additional medical acts will be performed by nurses, which is not covered currently by the current legal framework. So we have to view that through the scientific committee, who will process the deliverables taken by Savvas to complete them and have a bill tabled in the parliament through the minister. So a huge preparation work is currently affected. And the fact that Savvas had started so early accelerates the RRF absorption. And so we have double gratitude to all the panelists and the bodies they represent. An intervention off mic. There have been private companies for years that offer such kind of services, especially for clinical trials, and have an important participation in this action. I don't know whether you have analyzed such kind of data from the private sector. Second, let me ask, home care or municipal offices, have you taken them into consideration that they might perhaps also contribute? If you allow addressing with regard to hospital at home, this regards patients that will be admitted in the hospital. So we do not discuss home care of any kind, or community care, or palliative care, or whatever. We deal with patients that they would have been admitted in hospital. So this part of the legal arrangement that we want to introduce now regards this specific category of patients who currently burden the national health system. Burden not in the way that they are allowed, but that they are hospitalized in already burdened hospitals. So we try to decentralize those services and put them back at home. With regard to private sector, we have never excluded anyone. So we'll see in the future how this legal regulation will be introduced. But currently we focus on specific target group, and we see how the private sector will contribute. It's not clear yet. Municipal offices concern the primary degree care. Here we discuss the secondary degree care. There's also another project on primary care under Mr. Themistoklos, which concerns these patients who are served by GPs at home. That's another point. We should conclude here. It was a marathon indeed, and the conference goes on tomorrow. I would like to warmly thank the speakers. We have had a very accurate picture of what home care will involve, and we can only hope that this work that you planned and have studied, that we implemented, and especially to be communicated to the beneficiaries.